Thrombin generation, as you heard, is an important treatment target. Now, after cardiac surgery, thrombin generation is severely impaired on average by about 50%, and I'll show you that. But the reason for that is, one is, like every other coagulation factor, factor 2 drops by about 40% after cardiac surgery due to hemodilution, consumption, blood loss, and so on. So you heard about clotting time and clot formation time. So they measure, essentially a component of it is thrombin generation. And then you've got INR, PT-INR, which measures thrombin initiation. But those are just basically the beginning of clot formation. You're not really measuring the entire clotting thrombin generation process. Bottom line is we don't have a really good measure, but we do use INR to guide therapy for PCC. So if you're bleeding and your INR is over 2, I think it's fair to say that you need to treat it even over 1.5. If you're bleeding and everything else is normal and it's not surgical, then generally you do want to go ahead and treat it. So PCCs versus plasma is the question. This was a pilot study, but there was pretty strong signal that there was hemostatic effectiveness was higher in the PCC arm. Chest tube drainage was significantly different, cut by half in the PCC arm. Severe massive bleeding was almost cut by half, almost significant in 120 patients. That's pretty impressive. Allogeneic units were dropped, and you almost eliminated the need of plasma. So I think you're going to eliminate plasma transfusion in cardiac surgery if these results hold out in the main study. I think the preliminary evidence was very positive, but whether or not that's going to pan out in the main study, as I mentioned, we should know hopefully by end of next year.